Hello everyone, welcome. In this presentation, I'll focus on the most important points of hypertrophic cardiomyopathy, and I will actually go through different cases and find out what's most important to solve a question regarding hypertrophic cardiomyopathy. So first we have this case. So this is our practice problem number 1. So here, while playing soccer, an 18-year-old Caucasian male collapses and suddenly dies. And he had no significant past medical history, and nor had he taken any medication recently. This patient's autopsy is likely to demonstrate, so the most likely diagnosis or most likely answer is massive cardiac hypertrophy. So massive cardiac hypertrophy is a typical manifestation of hypertrophic cardiomyopathy which occurs in young Caucasian males, and they actually succumb to death suddenly due to sudden cardiac arrhythmia. Here we have another problem. A 16-year-old Caucasian male collapses and dies suddenly while jogging. Autopsy reveals significant left ventricular hypertrophy, predominantly affecting the septum. There are no valvular abnormalities. The patient's family history is significant for an uncle who died suddenly at age 20. Assuming that this patient has died of an inherited condition, the relevant mutation was most likely the one affecting which of the following structures? So what is the most likely mutation in this patient? Pick your answer. So my answer is beta myosin heavy chain, a cardiac cell sarcomere protein. So here this is a typical presentation of a patient with hypertrophic cardiomyopathy, and you can see the patient history also that one of his uncle also died suddenly at age 20. So hypertrophic cardiomyopathy is actually an autosomal dominant condition, so 50% of the child actually inherit this condition, and the mutation is mutation in a sarcomere protein which is beta myosin heavy chain. So hypertrophic cardiomyopathy are most commonly familial, and the inheritance patterns is most commonly autosomal dominant, and the mutation is a mutation in beta myosin heavy chain. Hypertrophic cardiomyopathy can be associated with Friedreich ataxia, and the most common manifestation is syncopal attack during exercise, and in some cases may lead to sudden death in young athletes due to sudden ventricular arrhythmia. And on examination, the patients commonly have a systolic murmur due to obstruction in the left ventricular outflow. Also they have a S4. So this S4 occurs due to reduction in the volume inside the left ventricle. So as there is hypertrophy of the left ventricular muscle, the volume inside the left ventricle is reduced. So during diastole, the left ventricle cannot be filled properly with blood. So when there is atrial systole or atrial kick, it tries to push the blood from atria against the ventricle. So it creates turbulence. So you have the S4 sound. So I will actually try to help you listen this sound. So you can listen this sound with the help of a headphone. So please wear your headphones, and now you can listen to the S4 sound found in hypertrophic cardiomyopathy. Now you can compare this S4 sound with the normal first and second heart sound. So now I will show you the normal first and second heart sound. So here, so you can see the normal second and first heart sound. So listen now, this is the normal sound. So as you can see that in normal first and second heart sound, during the first sound there is no what should I say, splitting or some added sounds, but in S4 you have an extra sound just before the first heart sound. So you have to look carefully So again, I'm going to show you or make you listen the S4. So here now please listen to S4 carefully and focus that during the fast heart sound there is something going on, something extra. So just before fast heart sound there is an extra sound, and as in each cardiac cycle you have only 0.8 seconds, and the systole occurs within 0.3 seconds and the diastole in 0.5 seconds, the heart sounds are pretty close. So it's hard to differentiate between them, but if you focus you can actually hear some extra sound just before the fast heart sound. So please notice again. Okay, so that's all. And those patients can also have mitral regurgitation due to impaired mitral valve closure. So now we have another practice problem. So this problem states that a 24-year-old Caucasian male with documented harsh systolic murmur on cardiac auscultation dies suddenly. His father and uncle also died suddenly in their 30s. A gross autopsy specimen of his heart is shown on the slide below. So here is a gross specimen. And now, which of the following would most likely increase the intensity of this patient's murmur? So you should pick an answer. So my answer is sudden standing. So first of all, this is a case of hypertrophic cardiomyopathy, because you see the harsh systolic murmur and you see the autosomal dominant inheritance, and ultimately you see that there is increased hypertrophy of the septum and also hypertrophy of the left ventricle here. So this is actually a superior view, superior section. So we are seeing the heart from an above portion, and this is the right ventricle. So this is the left and this is the right ventricle, and this is the hypertrophied interventricular septum or IVS. And the reason why sudden standing causes increase in murmur is actually depicted in the later slide. So here you can see that Valsalva and standing up actually increases the intensity of the murmur of hypertrophic cardiomyopathy. And the main reason is when you stand up when someone does a Valsalva maneuver, there is actually a reduction in venous return. And if venous return is reduced, it will lead to a reduced preload. And if preload is reduced, the left ventricular and diastolic volume will reduce. And suppose we have an heart here. So suppose this is the left ventricle, and left ventricle has connection with the left atrium. Suppose this is the left atrium, and also there is an outflow. And suppose this is the interventricular septum. So whenever someone has an high volume inside the left ventricle, the high volume will actually press the ventricle, and that's why the outflow can be open. But whenever someone has a low volume, now the septum actually will move closer, and now there will be increase in obstruction. So this is the dynamic there will be increased dynamic obstruction of the left ventricular outflow, leading to an increase in intensity of the murmur. And whenever someone increases afterload, like by hand grip or something like that, there will be decreased obstruction, and that's why there will be decreased intensity of the murmur of the hypertrophic cardiomyopathy. Now we have another practice problem. A 34-year-old Caucasian male with 2 recent episodes of exertional syncope is found to have a harsh systolic murmur on cardiac auscultation, and he also has asymmetric interventricular septum hypertrophy on echocardiography. His father died suddenly at age 30. This patient's symptoms are most likely explained by left ventricular outflow obstruction created by, so the answer here is number 3, C. So mitral valve cusp and interventricular septum. So as you can see from the previous picture, that if this is the left ventricle and if this is the connection of the left ventricle with the left atrium, so here is the left atrium and here is the left ventricle and here is the aortic opening. So whenever you have systole, during systole the mitral valves actually come closer to the aorta, and the mitral valve and interventricular septum actually creates an obstruction of the left ventricular outflow, because mainly the septum is dilated and the mitral valve is actually a bit flabby, and that's why there is a dynamic obstruction of the left ventricular outflow. Here we have another practice problem. A 23-year-old Caucasian student collapses and dies suddenly while taking an examination. She had no significant past medical history. The myocardial histology pictured below suggests which of the following causes of this patient condition. So the most likely diagnosis is hypertrophic cardiomyopathy. So here what you can see is extreme myocardial disarray. So the myocardial cells are not lined parallelly, but rather they are arranged very irregularly, and in between myocardial cells you can see some white patches which are actually areas or focus of fibrosis. Here you can compare with normal myocardium where there is straight or horizontal and parallel arrangement of the myocardium, but here you cannot see any parallel arrangement. So there is myocardial disarray and fibrosis. So it's important to remember. So that in case of hypertrophic cardiomyopathy, there is ventricular hypertrophy with septal predominance, and also in histology we will have myofibrillar disarray and fibrosis, and there is obstruction of the there is actually obstruction of the left ventricular outflow due to asymmetric septal hypertrophy, and during systole there is anterior motion of the mitral valve, and this septum and anterior motion of the mitral valve during systole actually creates a dynamic outflow obstruction, which might lead to dyspnea or possible syncope, especially during periods of exertion. So here we can see the concentric hypertrophy of the left ventricle. So here is the left ventricle, and as you can see, the chamber volume is actually reduced. So there will be a diastolic dysfunction, and it might lead to a diastolic heart failure where we get an S4. And the treatment for hypertrophic cardiomyopathy is cessation of high intensity exercise or athletics, and the patient can also use beta blockers or non-dihydropyridine calcium channel blockers like verapamil. And if someone has a high risk of arrhythmia, he or she might get an implantable cardiac defibrillator. So that's all from me today. Thanks all for watching my video.